Hello, good afternoon, and thank you for having me back. I will be talking about vascular loops in this session and their significance. My lecture will be divided into three parts, which begins with introduction focusing on anatomy, followed by whether vascular loop is symptomatic, and ending with vestibular paroxysmia. Let us begin with some simple anatomy. The area of interest to us in today's lecture would be the cerebellopontine angle. As the name suggests, it is the area between the pons, which is green in color here, and the cerebellum. The cerebellopontine angle contains cranial nerves 6, 7, and 8, blood vessels such as the anterior inferior cerebellar artery or the ICAR, and some veins. There is also the flocculus of the cerebellum and the choroid plexus. Often we find that the ICAR, which is the red structure in this picture, loops on the vestibular cochlear nerve, which is labeled here as CN8 or cranial nerve 8. T2 weighted MRI scans are ideal in identifying ICAR vascular loops without having to cut into the patient. The best landmark is to look for the cochlea first. Then you will be able to see the 7th and the 8th cranial nerve usually traveling in parallel. Vascular loops seen on MRI can be graded using the Scheffler classification. Type 1 or grade 1 is when an ICAR vascular loop borders the internal auditory meatus, where in this picture, the vessel is seen running alongside the internal auditory meatus of the left ear without extending inside. Type 2 is when the loop insinuates itself into the internal auditory meatus but occupies 50% or less of the canal as seen in the right side of this scan. And type 3 is when the loop occupies more than 50% of the canal, where in this picture, it is seen almost reaching the basal portion of the cochlea. Is vascular loop symptomatic? Vascular loop causing compression of the 5th cranial nerve, resulting in trigeminal neuralgia, was firstly suggested by Dandy in 1934 and later by Gardner and Miklos in 1959. This concept was then extensively expanded to try to explain disorders of various cranial nerves. More presentations, known as compressive syndromes, which include hemifacial spasms, glossopharyngeal neuralgia, and geniculate neuralgia. In 1975, Janetta proposed that the redundant arterial loops at the cerebellopontine angle may interfere with the 8th cranial nerve, resulting in symptoms of vertigo, tinnitus, and auditory sensorineural hearing loss. All pathophysiological theories are based on a common theme. A redundant vessel adhering to a cranial nerve causes chronic ectopic excitation. This results in reorganization of the nervous nucleus, causing nervous hyperfunction. This means the chronic compression can result in regional nerve demyelination, reorganization of the nerve, and axonal hyperactivity that results in tinnitus, hyperacusis, or vertigo. Another theory is that disturbances in the distribution of blood flow results in reduced vascular perfusion of the nerve, which results in otological symptoms such as hearing loss and tinnitus. It was suggested that this pathophysiological procedure is restricted to the entrance area of the cranial nerve root, also known as transition zone, that being the junction area between the central and peripheral myelin, where defects may occur. A unique feature of the 8th cranial nerve relating to neurovascular compression is the long transition zone, extending between 9.28 mm to 13.85 mm from the root entry zone, which leaves a much longer segment susceptible to vascular compression. So what kind of compressive symptoms can we expect from the compression of the vestibular cochlear nerve? As the name suggests, it carries two main functions, which is for hearing and balance. If there is any dysfunction, we can expect to get hearing problems, tinnitus, and imbalance. A quick search in Google Scholar for keywords of vascular loop and symptoms has gotten me 244,000 results. You will find an array of papers from case reports such as this, where a 33-year-old lady presents with tinnitus for 4 years, and the only positive finding is a vascular loop on the 8th cranial nerve. However, the patient refused surgery, and we will never know if elevating the vessel would resolve her symptoms. Then, there was a question of vertigo too. Another patient had a 2-year history of disabling vertigo with tinnitus. MRI was suspicious of a vestibular schwannoma, and during the surgery, they found a vascular loop, which was mobilized and rerouted. The tumor was left behind. The patient woke up from surgery with symptoms resolved. More and more papers then presented case series based on their experience. 8 patients here with severe vertigo underwent surgery, including nerve resection medial to the vascular loop. Rather drastic procedure, but luckily most of the patients improved. But can we conclude that the problem was the vascular loop and not the nerve? With time, as more centers now have MRIs, we find more vascular loops are being diagnosed, and that has allowed more subjects to be compared with, such as in this paper with 33 patients who reportedly having vascular loops, and there was no significant association detected between the Schefter grade and the otological symptoms. Another paper with 64 patients who has vascular loop also had no significant correlation between the vascular loop and the symptoms. And here, with an even larger sample size of 98 patients with vascular loops, also showed no significant association between the vascular loop and the audiovestibular symptoms. Of course, then we needed something more powerful, which is a meta-analysis. Cheddar proceeded to analyze 32 papers. Among the patients with vascular loops, he compared those symptomatic versus asymptomatic, looking at individual symptoms. Those which had statistically significant increased odds ratio were subjects with unilateral sensory neural hearing loss with or without non-pulsatile tinnitus had an increased odds ratio of 1.56. Those with unilateral sensory neural hearing loss had an increased odds ratio of 1.99. And patients with unilateral non-pulsatile tinnitus had an increased odds ratio of 1.35. He also noted that patients with pulsatile tinnitus had 80 times more odds of having a vascular loop. Unfortunately, Cheddar found that there was not enough quality data to analyze the significance between vascular loops and vertigo. What does this all mean? He concluded that these vascular formations may contribute to unilateral sensorineural hearing loss in some cases, but rarely be the only underlying cause. And subjects with pulsatile tinnitus were 80 times more likely to have vascular loops in contact with the 8th cranial nerve than patients with non-pulsatile tinnitus. Therefore, it seems reasonable that in patients with pulsatile tinnitus, diagnostic workup should include MRI scans of the internal auditory canal. If a vascular loop is found in contact with the affected cranial nerve 8 and no other cause for pulsatile tinnitus is identified, it is possible that surgical intervention may be beneficial in these cases, but it was not explored in the study by Cheddar. Vestibular paroxysmia. Vestibular paroxysmia, or VP, is a condition resulting in recurrent, short bouts of vertigo defined by the Classification Committee of Bereni Society as definite when one has more than 10 attacks of spontaneous vertigo lasting under a minute, and probable when there are more than 5 attacks lasting for under 5 minutes. These attacks are stereotypical in phenomenology. Response to carbamazepine 200 to 600 milligrams per day, or oxcarbazepine of 300 to 900 milligrams per day, and are not better described by any other diagnosis. While auditory symptoms are not part of the diagnostic criteria, patients may experience tinnitus or hypo or hyperacusis. As symptoms can be debilitating, it is fortunate that the prevalence is rare, with less than 2 cases in 2000, or in a study involving a tertiary clinic managing vertigo and dizzy patients, less than 4% of almost 18,000 patients had vestibular paroxysmia. While there is no gender preponderance seen, the mean age reported in vestibular paroxysmia case series range between 48 and 51 years. Vestibular paroxysmia is also seen in children and appear to have spontaneous remission with age and good long-term prognosis. Vestibular paroxysmia is thought to be part of a neurovascular compression syndrome, where the vestibular cochlear nerve is compressed by a vascular loop. A loop of the anterior inferior cerebellar artery, or ICA, is most commonly implicated, but may be formed by the posterior inferior cerebellar artery, the vertebral artery, or a vein. There are very few papers studying the effects of vascular loops resulting in vestibular paroxysmia. Both Sivarasan and Best showed that all of their vestibular paroxysmia subjects had vascular loops, and Sivarasan went further to suggest that the nerve angulation may be the specific feature in vestibular paroxysmia. However, those studies focused only on subjects who already had neurovascular compressive symptoms. So, we proceeded to carry out our own study, looking at all the MRI IAMs performed between 2010 and 2020 with the aim of studying the association between audiovestibular symptoms and the presence of vascular loops. We also wanted to look for any association between vestibular paroxysmia and vascular loops. 470 MRI IAMs were performed between January 2010 and June 2020. 233 subjects were included in this study, of which 71 had vascular loops and 162 had normal MRIs, which were used as controls. The 71 patients with vascular loop made up to 15.1% that fell within the 14 to 34% range of prevalence of vascular loops reported by MRI in any population. In terms of which side was the vascular loop situated, the majority distribution of vascular loops among our study group was bilateral at 49%, followed by right-sided with 35%, and then left-sided with 16%. This made up to 106 ears affected by the vascular loop. In terms of the type of vascular loops, of the 106 affected ears, majority were type 1 at 55.7%, followed by type 2 at 38.7%, and type 3 at 5.7%. This differed slightly from the other reports, which had reported type 2 as most commonly seen at 36.2%, followed by type 1 with 31.9%, and type 3 at 19.1%. The mean age in the vascular loop group was 47.9 and 45.9 in the control group. There was no significant statistical difference between the vascular loop group and control groups in terms of comorbidity and symptomology. Our first findings showed there is no correlation between gender, age, comorbidities or symptoms, and the presence of vascular loops. This means gender, age, comorbidities, or audiovestibular symptoms did not predict if a person had vascular loops. The 106 ears were compared with the 162 subjects without vascular loops. There were no statistically significant results when evaluating for audiovestibular symptoms in the absence or presence of vascular loops using the Schefter classification. This means that the degree of vascular loops based on the Schefter classification does not affect the audiovestibular symptoms significantly. Moving our focus now to vestibular paroxysmia, there were 37 subjects with 21 definite and 16 probable. Our study was a retrospective study from 2010, and the diagnostic criteria was published in 2017. Hence, the diagnoses were given based on the history given by the patients. The remaining 196 out of the 233 subjects without vestibular paroxysmia were used as controls. Patients with vestibular paroxysmia were significantly older at 51.8 years as compared to the controls with a mean age of 45.6 years. There were a higher number of vestibular paroxysmia patients presenting with sensory neural hearing loss at 97.3% when compared with those who did not have vestibular paroxysmia at 80.1%. This is also likely due to age. Otherwise, there were no other significant differences between the two groups. Only 27% of the 37 patients with vestibular paroxysmia had vascular loop, with 27 vestibular paroxysmia reported not having any vascular loop. The odds of having a vascular loop giving rise to a vestibular paroxysmia was not statistically significant at 0.82. While there is evidence that the vascular compression of the vestibular cochlear nerve is the most probable cause of the vestibular paroxysmia, our study has shown that vascular loop is most likely a normal variant and may or may not result in audiovestibular symptoms without an increased odds of having vestibular paroxysmia just by having a vascular loop. Do you remember this meta-analysis? We found the lack of association between vascular loops and audiovestibular symptoms have been reported in many studies, including those published after the meta-analysis. As a reminder, the meta-analysis has shown subjects with vascular loop complaining of unilateral hearing loss or pulsatile tinnitus were more likely to have a vessel that was compressing the vestibular cochlear nerve. However, the authors have also cautioned that discovery of a vascular anatomy should not be considered as the primary causative diagnosis in all cases, as there were subjects who were asymptomatic with vascular loops. So, if these loops are causing audiovestibular symptoms, logically, surgery to decompress or move the offending vessels away should help relieve the symptoms. Among those reported, invasive neurosurgical microvascular decompression as a treatment only provided mixed results. This is a photo of an intraoperative view demonstrating a pledget separating an artery, seen here with white arrows, from the nerve, which is labeled by black arrows. Cadaveric studies have also shown that it may be normal to find intimate anatomical relationship between the nerve and ICA in the CP angle, and may be as common as 50% of the time to find a vascular loop entering into the internal acoustic meatus. Hence, if a vascular loop is a normal variant, why are some symptomatic and some are not? Some studies explain that the symptoms develop only when the vessels elongate, whether it's congenital or acquired, or if it stiffens due to arteriosclerosis, or become fixed to the nerve due to arachnoid adhesions, and they compress the nerve. Others attribute it to aging, where there is stiffening of the arterial walls, leading to increased pressure on the nerve, as well as stretching of the nerves due to age-related decreased cerebrospinal fluid and cerebral atrophy, resulting in the nerves making contact with the arteries. Coming to the end, our study further solidifies the diagnostic criteria for vestibular paroxysmia, which was involving mainly the clinical history of the patient and does not require an MRI scan, as more often than not, the vascular loop is just an incidental finding. Identifying a vascular loop may lead to the referral for surgical decompression, but should only be reserved for refractory cases, and like the diagnostic criteria states, first-line therapy with carbamazepine or oxcarbazepine is preferred. In conclusion, the vascular loop is a normal variant, which may or may not give rise to audiovestibular symptoms or vestibular paroxysmia. Clinical assessment is still most important tool in deriving a diagnosis of vestibular paroxysmia, and MRI may be useful to rule out other central causes. I hope the lecture was insightful. I welcome any questions, or you may email me at this email address. Thank you.